Hello, and welcome to today's webinar, Breast Cancer Trends and the Importance of Prevention. I am Dr. Barbara Malkus, Board President for Massachusetts Breast Cancer Coalition, and I'd like to thank you all for joining us today. Massachusetts Breast Cancer Coalition is dedicated to preventing environmental causes of breast cancer through community education, research advocacy, and changes to public policy. I am pleased to welcome today's speaker and Massachusetts Breast Cancer Coalition board member, Dr. Jill Oxley. Dr. Oxley is a breast surgeon for Cape Cod Hospital and the director of the hospital's breast program. Her clinical interests include benign and malignant breast disease, risk assessment, and high-risk breast cancer screening and oncoplastic breast surgery. Dr. Oxley is a member of MBCC's board of directors. And Dr. Oxley, it is my pleasure to welcome you here today.
Thank you, Dr. Malkus, and thank you for the invitation to speak today. So, as Dr. Malkus said, we're going to talk about breast cancer trends and the importance of prevention. So first, we will review recent breast cancer data and some of these trends. And then we'll talk about primary prevention, specifically risk reduction and modifiable risk factors, followed by secondary prevention and screening. So, what are the most recent numbers? Well, the American Cancer Society estimates that this year, 297,790 women will be diagnosed with invasive breast cancer in the U.S., and there will be another 55,720 diagnoses of DCIS, ductal carcinoma in situ, which is non-invasive breast cancer. The American Cancer Society also estimates that there will be 43,170 deaths from breast cancer this year. And that is the second highest cause of cancer death behind lung in women. In Massachusetts, there will be 6,770 women diagnosed with invasive breast cancer and 760 deaths from breast cancer. But in Massachusetts, that is number 4, behind lung cancer, pancreatic cancer, and colon cancer. And so what that translates to is that 13% of women will be diagnosed with breast cancer in her lifetime, and 3% of women will die from breast cancer. And so to look at this graphically, you can see on the right, the breast cancer is the most commonly diagnosed cancer in women, but it's actually the most commonly diagnosed cancer overall, even higher than prostate cancer, which has over 288,000 projected diagnoses this year. And then the deaths from breast cancer, number 2, behind lung. And so that 13% translates into 1 in 8 women will develop breast cancer, and the risk of death is 1 in 39. But 1% of new breast cancer diagnoses also occur in men, for an estimate of 2,800 cases this year. But a man's risk, however, is only 1 in 833. So the median age that a woman is diagnosed with breast cancer is at 62. The median age at death is at 69. The risk of having a breast cancer diagnosis increases with age to the 70s, but the risk of dying from breast cancer continues to increase into the 80s. And the majority of breast cancers, 83%, are diagnosed in women age 50 or older, and the vast majority of deaths, 91%. But half of these deaths occur in older women, age 70 or over. But 1 in 6 breast cancers overall are diagnosed in women in their 40s. 1/3 of breast cancers in Black, Asian, and Hispanic women are diagnosed under the age of 50, and just 1/4 of breast cancers in white women are diagnosed under the age of 50. And so to look a little bit more into these variations by ethnicity, whereas the median age of diagnosis of breast cancer is 62, that does vary by ethnic group. Hispanic women are the youngest at diagnosis with a median age of 57, followed by Asian and Pacific Islanders at 58, Black women at 60, American Indian and Alaska Native women at 61, and white women at 64. And the median age of death, again, we said was 69, but white women tend to be a little older at 70, whereas Asian, Pacific Islander, and Black women, their median age of death is 63, and Hispanic women are the youngest at 62. And so to look a little more in the incidence rates. So the age-adjusted rates of a diagnosis of breast cancer per 100,000 women for the US is 128.1. Massachusetts is one of the higher states with an incidence rate of 137.6. And Barnstable County is the second highest county in the state at 154.4, second only to Nantucket. But these incidence rates also vary with ethnicity. White women do have the highest rates of breast cancer at 133.7 diagnoses per 100,000, followed by Black women at 127.8, American Indian Alaska Native at 111.3, Asian Pacific Islanders at 101.3, and Hispanic or Latino women at 99.2. And that's illustrated graphically on this slide, with the incidence rates being the blue bars, highest in white women, followed by Black, Asian, American Indian Alaska Native, Asian Pacific Islanders, and Hispanic. But although these groups are kind of broad, there can be differences within ethnic groups. And so while the incidence rates are highest in Black women, the breast cancer death rate, however, is highest in Black women. And these mortality rates are illustrated in the red bars. And we'll talk a little bit more about mortality in a minute. And so Black, Hispanic, and American Indian Alaska Native women are less likely to be diagnosed with local stage breast cancer than Asian Pacific Islander women and white women. Black women have a higher proportion of distant stage breast cancer compared with other women. Black women have the highest proportion of high-grade tumors. Black women have more likely being diagnosed with hormone receptor negative and HER2 negative, also called triple negative breast cancers. And so what are these actual numbers? So Black, Hispanic, and American Indian women have a range of local stage breast cancer from 57 to 60%. So almost 2/3 of those diagnoses are going, or less than 2/3 are going to be early stage, but Asian American and white women have 65 to 68%, so 1/3 or greater. And then we're talking about triple negative breast cancers. Black women have this diagnosis 19% of the time, whereas Hispanic and American Indian women are diagnosed 11% of the time, but only 9% in white and Asian American women. And so that's illustrated in this table here. So the local stage rates are highest for whites and Asians, but regional is highest for Black women, who also have the highest rates of triple negative breast cancer. And so this next graph shows breast cancer incidence by age and ethnicity. So overall, white women are at the top of this graph here with this kind of light gray color. But before age 40, Black women, the bright pink, have the highest incidence rate. And Asian Pacific Islander women have the second highest rate after white women between the ages of 40 and 45, so in the middle here. Black women have the highest breast cancer death rate, except for women aged 70 to 75, among whom American Indian and Alaska Native women have the highest rates. And the disparities between incidence and mortality between Black women and white women are largest in young women, this graph on the right, and then the disparities decline with age. For example, the breast cancer death rate for Black women is between 1.8 and 2.4 times higher than that for white women in the group aged 20 to 49. but only between 1.1 and 1.2 times higher in the group age 70 and older. And so a lot of the discrepancies in younger women reflect the higher proportion of triple negative breast cancer, which do occur at a younger age and have a lower likelihood of insurance coverage, which is associated with later stage of diagnosis. And it is felt that a lot of these women will have reduced access to high quality treatment. This next graph details a little bit more about the breast cancer incidence rates by these tumor subtypes, along with race, ethnicity, and age. And so for all women, which is the top graph, age 20 and older, incidence rates of the most common subtype, hormone receptor positive, HER2 negative breast cancer, are highest in white women at 141 cases per 100,000, followed by American Indian Alaska Natives and Black women. However, rates among young Asian Pacific Islander women, so in the second graph between the ages of 29 and 40, are only slightly lower than in white women, 50 versus 53 per 100,000. And so this may partly reflect differences in risk factor prevalence among the younger Asian American women who are more likely to be first-generation immigrants. One of the least common subtypes, or less common subtypes, is what we call triple negative breast cancer. And so that's this last section of all of these graphs. And you can see that triple negative breast cancers are most common in Black women, at 37 per 100,000, with rates almost 2 times higher than white women at 19, and 3 times higher than in Asian Americans. And this is true for both younger and older women. And so inherited genetics may explain some of this higher risk, but multiple studies are also looking at the additional contribution of factors such as neighborhood segregation, socioeconomic status, access to healthcare. But then for the least common tumor subtypes, the ones that have the HER2 receptor, these rates are fairly similar across all ethnicities. So breast cancer incidence. The incidence of breast cancer rose dramatically during the 1980s and 1990s, largely because of the detection of asymptomatic disease with a screening mammogram. Screening mammography went from 29% of women having screening in 1987 to 70% in 2000. And the majority of these breast cancers that were being detected with screening mammograms were early stage, especially non-invasive breast cancer or ductal carcinoma in situ. And so for women age 50 and older, the rate of this diagnosis of DCIS increased more than tenfold, from 7 cases per 100,000 in 1980 to 73 cases per 100,000 in 2000. And the rate of invasive breast cancer, in contrast, increased only 40%. So 275 cases per 100,000 to 380. The incidence of non-invasive breast cancer has continued to increase until about 2008, but then has been decreasing slowly since then, about 1.5% per year. There was a decrease in the diagnosis of invasive breast cancer from 2001 to 2004, and this has been attributed to decreased use of hormone replacement therapy. The Women's Health Initiative reported results of a randomized trial linking estrogen and progesterone hormone replacement therapy to both increased risk of breast cancer and heart disease. And so with less use, we had less breast cancer diagnoses, but this decrease was mostly limited to white women and, not unexpectedly, hormone receptor positive disease. And then after 2004, invasive breast cancer incidence began rising again, slowly, about 0.5% per year since. And a recent ecologic study has attributed this to increases in body mass index and continued declines in the fertility rate. And body mass index and reproductive factors, as with the use of hormone replacement therapy, primarily influence the risk for hormone receptor positive tumors. There's also been an increase in local stage disease of a little under 1% per year, from 75 per 100,000 in 2004 to 86 per 100,000 in 2019. A slow decrease in regional disease, 0.7% per year, but an increase in distant disease. That rate was 2.4% per year from 2004 to 2011, and then has been less than 1% per year since, over the most recent time frame, 0.9%. And some of this has been attributed to more advanced imaging. More women are obtaining full body scans, staging scans like PET scans, CAT scans, and bone scans with the diagnosis of regional disease. So it's felt that this decrease in regional disease is just shifting toward the distant disease. And this is illustrated graphically here with the red bar on top, so the red line, with a little bit of a dip, but then continue to increase. Regional has the very slow decline, and distant, the very slow increase. This next graph describes the trends in female breast cancer incidence rates by both race and ethnicity. And so, again, we saw that white women do have the highest incidence of breast cancer, so that's the light gray line at the top. And then over the most recent 5-year period of available data, 2015 to 2019, incidence rates increased among all racial and ethnic groups, although the rates were slower among white women, 0.5% per year, and Black women at 0.7% per year, than among Hispanic women at 1.4% per year, and highest with American Indian Alaska Natives at 2% and Asian Pacific Islanders at 2.1% per year. And then this next graph describes trends in breast cancer incidence rates by hormone receptor status and race. For all ethnic groups, hormone receptor positive breast cancer has been increasing since at least 2005 by about 0.9% per year in white women, 1.7% per year in Hispanic women, 2.3% per year in Asian and Pacific Islanders, and 2.5% per year in American Indian Alaska Native women. In Black women, now on this graph on the right, the Black women, the bright pink, are at the top. So the incidence rate for hormone receptor positive breast cancer increased 3.1% per year from 2005 to 2012, but has since stabilized. But the incidence of hormone receptor negative breast cancer has generally decreased or remained stable in all ethnic groups, although again, more common in Black women than any other group, with the rates in the bright pink here, and everybody else is kind of clustered below. And so the reasons why these trends are diverging are somewhat unknown, but likely reflect changes in risk factors that correlate with the specific subtypes. And so, as we said earlier, the risk of hormone receptor positive breast cancer does decrease with the number of childbirths, but that's also associated with a higher risk of triple negative breast cancer, although that can be decreased by breastfeeding. And so with decreasing fertility rates, we are seeing increases in these hormone receptor positive breast cancers. The fertility rate for US women at one point was as high as 118 births per 1,000 women between the ages of 15 and 44. By 2007, this had decreased to 69.4 births per 1,000 women, and then in 2021 hit an all-time low of 56 per 6 births per 1,000 women. And there's also been a shift toward later age at first childbirth, which is also associated with an increased risk of hormone receptor-positive breast cancer. So now let's look at mortality. There was an overall increase in deaths from breast cancer of 0.4% per year from 1975 to 1989. Then there was a decline of an overall 43% through 2020. But this decrease in deaths from breast cancer has slowed. From 1998 to 2011, the mortality rate decreased by just under 2% per year, but then from 2011 to 2020 has been only 1.3% per year. And so this decrease may reflect the steady increase in incidence and relatively stable use of screening mammography in this time frame. But then when we look at the decreases by ethnic group, we see that Hispanic, Black, and white women have declined at the highest rates, between 1 and 1.4%. The rate of decline is 0.6% per year in Asian Pacific Island women, and has been relatively stable in American Indians and Alaska Natives. And that's illustrated on this graph here. But what's interesting is prior to 1980, so right around here, breast cancer mortality rates were fairly similar between Black women and white women, but began diverging with the dissemination of advances in early detection and treatment, mammography, and the use of tamoxifen. And so this racial disparity peaked in about 2011 and has persisted, with the rate of death from breast cancer being 40% higher among Black women than white women between 2016 and 2020. And this racial gap has been in large part attributed to historic differences in access to care, lower quality care, lower quality screening, and substandard treatment. But even looking at the same diagnosis of having a hormone receptor positive breast cancer, a recent study that looked at mortality rates reported that Black women still have a 19% higher mortality rate for white women for this hormone receptor positive breast cancer, despite having a lower incidence. And so suggests that even when there is access to the same care, the benefit is not equivalent. And even though screening rates are currently similar between Black women and white women, the same study showed that Black women are more likely to be screened at lower resourced or potentially non-accredited facilities, and to have longer intervals between their screening mammograms and the workup of an abnormal study. So now we'll look at trends in treatment. And these vary by age, stage, and race, although the racial groups are really only limited to looking at white women versus Black women. So over recent years, approximately 63% of women are treated with breast conserving surgery or a lumpectomy, versus 33% treated with mastectomy, removing the entire breast. Younger patients under the age of 40 and those with larger or more aggressive cancers are more likely to be treated with mastectomy than breast conservation. We've also shown that increasing use of preoperative breast MRI exams, magnetic resonance imaging, has led to an increase in rates of mastectomy in women with early stage breast cancer, although fortunately this seems to be stabilizing. And so while mastectomy rates for early stage tumors overall are decreasing, the risk of removing both breasts, meaning having what we call a contralateral prophylactic mastectomy, those rates though continue to increase. And back in 1998, having a contralateral prophylactic mastectomy was done less than 2% of the time, but then by 2010 to 2012, this was approximately 30% of cases. And women who have a contralateral prophylactic mastectomy are more likely to be white younger, have a higher socioeconomic status, and are more likely to be at treatment facilities that are teaching hospitals or provide breast reconstruction. And the contralateral prophylactic mastectomy increases the cost of care, increases the morbidity or risk of complications, and has not been shown to improve survival. And then another trend in treatment, Black women with stage 3 disease, so that would be regional, are less likely to have a mastectomy and more likely to have radiation or chemotherapy alone. And this is illustrated on the next slide. And so the first graph shows all races, the second graph shows white women, and the third graph shows Black women. And the orange bars show that more white women with early stage disease, so stage 1 and 2, are more likely to be treated with breast conserving surgery or lumpectomy without radiation. However, this is likely secondary to an older age at diagnosis than Black women, because there are other studies that have shown lack of survival benefit to women over 65 or over 70, adding radiation to breast conserving surgery. The yellow bars in these graphs show that more white women with stage 3 disease are treated with mastectomy and chemotherapy than Black women. So over 55 here, but closer to 50 there. And the blue and pink bars, these represent women who did not have curative intent surgery or had no treatment at all. And so more Black women with stage 3 disease did not have really standard of care. So this would be radiation and chemo with no curative surgery. The pink bars, no treatment at all. There's also been more use of what we call genomic assays. And so the 21 gene recurrence score, or oncotype, is one of several commercially available gene expression assays that is used to predict the benefit of chemotherapy in addition to hormonal therapy for patients with hormone receptor positive, HER2 receptor negative, lymph node negative, initially, breast cancer. And patients with high scores, regardless of age or menopausal status, are going to be at increased risk of distant recurrence and therefore more likely to benefit from chemotherapy, whereas women with low scores were shown to have excellent outcomes with endocrine therapy alone. Although Black participants in this study had lower overall and distant disease-free survival rates compared with white participants, even with the same recurrence scores. Approximately 14% of white women and 21% of Black women with stage 1 and 2 disease received chemotherapy in this study. And then, although most patients receive chemotherapy in what we call the adjuvant or postoperative setting, the use of neoadjuvant before surgery chemotherapy is increasing, particularly in patients with HER2 positive disease and triple negative breast cancer. And so by doing chemotherapy first, that can lead to less extensive breast surgery. So for example, someone whose cancer is inoperable can become a candidate for surgery. Someone who would have required a mastectomy may be able to be treated with breast conserving therapy. And it can also reduce the risk, or reduce the extent of lymph node involvement. And so this has a potential to lead to less lymph node surgery, and less lymph node surgery means a lower risk of lymphedema or arm swelling that can result from removal of the lymph nodes in the underarm. And the American Society for Clinical Oncology recently issued recommendations to guide the use of this preoperative systemic therapy, including endocrine therapy in women with breast cancer. And by using either chemotherapy or endocrine therapy before surgery, we're able to identify women who do not achieve a complete pathologic response, meaning the extent of leftover disease, residual disease after surgery, can guide additional treatments after surgery. And so what are we seeing in breast cancer survival? Well, breast cancer survival depends on the stage at diagnosis. And so for the most recent 5-year availability of data, we can see that stage 1 breast cancer had 5-year survival greater than 99%, stage 2 at 93%, stage 3 at 75%, and stage 4 at 29%. And except for stage 1, for which survival is similar across all ethnicities, Black women have the lowest survival at every other stage of diagnosis, with the largest discrepancies between Black women and white women being between stage 3 and stage 4. And those are these 2 bars here. But survival also varies within these racial and ethnic groups. For example, one study found that Caribbean-born Black women have more favorable breast cancer survival than their US-born counterparts. And then when we look at the trends in survival by tumor subtype, again, for that same 5-year period, 2012 to 2018, triple-negative breast cancer still has the poorest prognosis compared with other subtypes. These cancers, again, are more likely to be diagnosed at a more advanced stage, and there are fewer effective treatment options. And similar to the overall differences by stage, Black women have the lowest survival for every subtype. But the largest discrepancy is seen with the more treatable breast cancers, such as hormone receptor positive HER2 negative and hormone receptor negative HER2 positive breast cancers. And those are illustrated here: hormone receptor HER2 negative and HER2 positive. And again, this is an area of investigation. Access to treatment, quality of treatment is being looked at, but also differences in tumor biology, other coexisting medical problems, and response to treatment. And one study looked at insurance status with regard to survival and found that that explained 1/3 of the excess risk of death among Black women versus white women. Another study looked at stage 4 or metastatic breast cancer and found that in areas where Medicaid expansion increased access to care, that these ethnic differences and racial differences went away. But again, studies have shown that Black women are more likely than white women to have delays in treatment, issues with coordination of care, and less likely to have guideline-driven care, even when controlling for insurance status. So to summarize these trends, breast cancer incidence continues to slowly increase and mortality continues to slowly decrease. Black women, however, have a 40% higher mortality than white women despite a lower incidence of breast cancer, and Black women have the lowest survival from breast cancer for any subtype and stage except stage 1. 8% lower than white women for favorable subtypes, 13% lower for stage 3 disease. So what can we do? Well, primary prevention deals with modifiable risk factors, and there are elements that increase risk and there are elements that decrease risk. And so there's lots of known risk factors for breast cancer. The highest risk is being female. The risk increases with age, as we saw earlier. Family history also plays a role, along with race and ethnicity. But there are lifestyle factors: higher body mass index, alcohol consumption, use of estrogen, progesterone, hormone replacement therapy, and smoking are all risk factors for the development of breast cancer, along with reproductive history. So having a younger age at the onset of menstruation, no pregnancies or fewer pregnancies, being over age 30 at the first full-term pregnancy, and having an older age at menopause are also associated with increased risk of breast cancer. There are certain breast biopsies that are not cancer, but that increase the risk. Something called lobular carcinoma in situ can increase the risk of breast cancer, along with atypia, so atypical ductal hyperplasia or atypical lobular hyperplasia. But regardless of the pathology, the number of biopsies that are performed to diagnose or rule out breast cancer is also associated with increased risk. Having dense breast tissue, especially after menopause, can increase the risk of breast cancer, or having had radiation to the chest earlier than the age of 30. There are some factors that decrease risk, fortunately. going through menopause prior to age 45, taking risk-reducing medications, having risk-reducing surgery, exercising, and even breastfeeding can all decrease cancer risk. And so what are some of these risk-reducing medications? Well, tamoxifen is a drug a lot of people have heard about. It's been used for the treatment of breast cancer for decades now. This was studied in women aged 35 or older who had a 5-year risk of breast cancer by the Gale model greater than or equal to 1.7%, or a 10-year risk by the Tyrer-Cuzick score greater than 5%, or had a history of lobular carcinoma in situ. These women were given 20 milligrams a day for 5 years and shown to reduce the risk of breast cancer by 49%. But if they had had atypia on a previous biopsy, then their risk was reduced by 86%. There's also a low dose option of 5 milligrams per day for 3 years for women who are unable or unwilling to take the full dose. The benefit, however, is less clear in women who are carriers of BRCA1 or 2 gene mutations. But overall, this has been shown to have a favorable risk-benefit ratio in premenopausal women. And for postmenopausal women, you need to consider her age and therefore relative remaining risk, whether or not she still has a uterus, and then other medical problems or comorbidities. The data for this medication effect, though, is not broken down by ethnicity or race. Raloxifene is a very similar medication to tamoxifen. These are both called SERMs, or selective estrogen receptor modulators. This was studied in the same type of patient group, postmenopausal women 35 or older with these risk scores or a history of lobular carcinoma in situ. The dose of raloxifene is 60 milligrams per day. And this has been shown to be less effective in long-term follow-up than tamoxifen, but this can be continued for more than 5 years and has another benefit of improving bone density. And so this has a lower risk of endometrial cancer and is therefore potentially preferred in women who still have her uterus. But we have no data on the use of raloxifene for carriers of gene mutations, and this is only for postmenopausal women, should not be used in premenopausal women outside of a clinical trial. There are other drugs called aromatase inhibitors that can be used for risk reduction. There were 2 large randomized controlled trials looking at these medications. The first looked at exemestane at 25 milligrams per day. Again, same group, postmenopausal women 35 and older with these risk scores of 1.7% or 5% or history of lobular carcinoma in situ. Exemestane was shown to reduce the incidence of breast cancer by 65% with a median of 3 years of follow-up. And anastrozole was studied in a slightly different patient population. These are postmenopausal women between the ages of 40 and 70. If they were younger, they had to have calculated risk 4 times higher than average, 45 to 60, at least twice higher than average, 60 to 70, at least 1.5 times higher, or if they had this Tyrer-Cuzick 10-year risk score calculated at greater than 5%. And with the use of anastrozole, these women had a reduced incidence of breast cancer at 53% at 5 years median follow-up. And aromatase inhibitors have also been shown to reduce the risk of a contralateral breast cancer, getting cancer in the remaining breast, in women who are BRCA1 or 2 mutation carriers with hormone receptor positive breast cancer who take these drugs as treatment. But with these other drugs, you need to consider the age of the patient and her comorbidities, and these medications should not be used in premenopausal women outside of a clinical trial. So risk-reducing mastectomies are also an option. They provide about a 90% reduction in breast cancer risk. Most commonly, this is going to be used in someone who has what we call a pathogenic or likely pathogenic mutation in a gene that imparts a high risk of developing breast cancer. It can be considered in someone with a compelling family history. It can be considered in someone who had prior chest radiation, but we don't know really the degree of risk reduction with other gene mutations that give at least a 2 times average risk of breast cancer. And it's not recommended for women with a history of lobular carcinoma in situ. Risk-reducing medication is preferred in these situations. But risk-reducing mastectomy is an option. It has been shown to be oncologically safe to spare the nipple, and there are options for reconstruction, which should be discussed if someone is considering this option. But there are also psychosocial effects that need to be discussed as well, because mastectomy has been shown in various studies to have a negative impact on one's body image, on the ease of forming new relationships, and also on the quality of existing relationships. And if the breast is removed, it can no longer function as a lactating organ or usually a sexual organ either, because nipple sensation and nipple function is usually compromised with mastectomy, even a nipple-sparing mastectomy. But what about these modifiable risk factors? So hormone replacement therapy, the combination of estrogen and progesterone for more than 3 to 5 years has been shown to increase the incidence of breast cancer by 26%. This also leads to an increase in breast density, which can lead to more abnormal mammograms. There are conflicting reports for the use of estrogen alone, and so the risk attributable to estrogen may depend on the duration of use, along with when it began, at the time of menopause or several years after. And it's not recommended for any women who are taking risk-reducing medications. Body mass index is another modifiable risk factor. So these are weight categories for women, for people age 20 and older. It takes into account height and weight. A BMI of between 18.5 and 24.9 is considered normal. 25 to 29.9 is overweight, and obese is a BMI of 30 or greater. And this is an independent risk factor for breast cancer, especially in white women. Interesting though, premenopausal women who are obese have lower rates of breast cancer overall, but higher rates of hormone receptor negative breast cancer. And women who are overweight or obese after menopause have between a 20 and 60% higher breast cancer risk than those who are lean. And studies have shown an increase of between 11 and 12% for every 5 units of BMI. And this graph is from the Million Women study, which looked at the relative risk of cancer incidence and mortality for several different cancer sites or types according to body mass index. Their reference range was a BMI of between 22.5 and 24.9. And these two graphs over here show premenopausal breast cancer on the left, postmenopausal on the right. And again, while increasing body mass index is associated with lower incidence and mortality from breast cancer in premenopausal women, both the risk of breast cancer and the risk of mortality increase with BMI in postmenopausal women. Exercise is another modifiable risk factor. Several studies have shown that moderate intensity physical activity between 150 and 300 minutes per week is associated with reduced risk of breast cancer. And more is better. Women with the highest levels of physical activity have lower rates of breast cancer, even when adjusted for body mass index. And these rates are between 19 and 23% in premenopausal women, 12 and 17% in postmenopausal women. And a meta-analysis that looked at 76 studies showed reductions in risk of breast cancer between 21 and 40%. The mechanisms for the risk reduction are somewhat unclear, but have been attributed to decreases in sex hormones, decreases in fat composition, increases in immune function, and changes in markers of insulin resistance. The sister study looked at women with a family history of breast cancer who were going to be at least 2 times more likely than average to develop breast cancer. That study showed that higher levels of physical activity were associated with lower rates of postmenopausal breast cancer. But exercise also lowers the risk of death among breast cancer patients, and that's shown in this graph here on the right. There is shown to be a 60% decrease in breast cancer mortality with even moderate physical activity. Then there's alcohol. So any alcohol intake increases the risk of breast cancer. Current recommendations are that women consume no more than 1 drink per day and no more than 3 drinks per week. Studies have shown a 10% increase in the risk of breast cancer for every 10 grams consumed daily. and higher alcohol intake is associated with higher rates of hormone receptor positive breast cancer. And so a standard drink is typically defined as shown in this graph, this picture here, as 12 ounces of regular beer, 8 or 9 ounces of a malt liquor, 5 ounces of wine, or 1.5 ounces of spirits, so 40% alcohol or 80 proof. These are National Institute of Health definitions, but the NCCN, National Comprehensive Cancer Network, has redefined a standard drink as 1 ounce of liquor, 6 ounces of wine, so good for the wine drinkers, but only 8 ounces of beer. The Nurses' Health Study looked at 105,986 women, and these women were followed from 1980 until 2008. This graph here shows the alcohol consumption with regard to risk, and this study showed significant increases in breast cancer risk with alcohol intake as low as 5 to 9.9 grams per day, or only 3 to 6 drinks per week. Binge drinking is also associated with increased risk, so it doesn't matter if it's a daily drinker or all at once. And the risk was associated with intake both in young adulthood and later in adulthood. And so while primary prevention deals with modifiable risk factors, secondary prevention deals with screening. Mammography saves lives. 9 randomized controlled trials have shown that mammograms are the only test shown to reduce deaths from breast cancer. 3D mammography, or digital breast tomosynthesis, has been shown to detect more cancers and recall fewer patients than 2D digital mammography, and this is particularly helpful in women with dense breast tissue. It's been shown that having annual screening mammograms between the ages of 40 and 84 reduces the risk of dying from breast cancer by 40%. And as we looked at earlier, 1 in 6 breast cancers are diagnosed in women in their 40s. 1/3 of breast cancers in Black, Asian, and Hispanic women, and 1/4 breast cancers in white women are diagnosed under the age of 50. And interestingly, 75% of women who develop breast cancer are considered average risk. But screen-detected breast cancers are more favorable, more likely to be diagnosed at earlier stages than cancers that are detected in women who don't have regular screening, or cancers that are detected in between routine screenings. And so for every 100 women who get a screening mammogram, 90 of them will be told their mammograms are normal. 10 will be asked to return for additional imaging, mammograms or ultrasounds. And of these 10, 6 will be assured then that their mammograms are normal. 2 will be asked to return in 6 months for a follow-up, and only 2 will be recommended to have a needle biopsy. And so the American College of Radiology and Society of Breast Imaging updated their guidelines in 2017. The American Society of Breast Surgeons updated theirs in 2019, and the NCCN, National Comprehensive Cancer Network, updated theirs last year. They all agree now that women who are at average risk of breast cancer should have annual screening mammograms starting at the age 40 and continue until her life expectancy is less than 10 years. And so to put that in real numbers, a US woman who is currently 78 years old has a life expectancy on average of 10.2 years. And it is recommended that every woman have a formal risk assessment at age 25 or no later than age 30, especially for women who are Black or of Ashkenazi Jewish descent. And so what makes someone high risk versus average risk? How does breast density factor in? So all states now require reporting of information about breast density. Connecticut was the first in 2009. In Massachusetts, we started doing it in 2015. And in 2019, the Department of Health and Human Services and the FDA changed the Mammography Quality Standards Act to include reporting of dense breast tissue. And women with dense breast tissue may benefit from supplemental screening. And so in the US, roughly 10% of women have mostly fatty breasts, 10% have what we call scattered areas of density. These two categories are not dense. Another 40% have heterogeneously dense tissue, and another 10% have extremely dense breasts. So roughly half of US women have dense breast tissue and half don't. And dense breast tissue may increase the risk of breast cancer after menopause, but for all women, a cancer may be harder to see in a mammogram with dense breast tissue. And so 3D mammography or breast tomosynthesis is better than 2D for women with dense breast tissue, but women with dense breast tissue may benefit from supplemental screening. So ultrasound exams and MRIs, however, are more likely to detect things that are not cancer, although they can pick up more cancers. And MRI screening is available for women who are at increased risk of breast cancer. A fast MRI is a shorter study that is not covered by most insurances, but is an option for women who are not at high risk but have dense breast tissue and are interested in pursuing supplemental screening. And so the guidelines for screening are broken down by breast density, by age, and also whether or not the woman has a history of breast cancer. And so the American Society of Breast Surgeons guidelines are illustrated here. And again, for women who are at average risk of breast cancer who do not have dense breasts, annual mammography is preferred starting at age 40. Women who do have dense breasts can consider adding supplemental imaging to that screening. Women who are at higher than average risk, the recommendations for screening are further stratified. If this risk is from a gene mutation, so hereditary susceptibility from having a pathogenic gene mutation, or if this woman had chest wall radiation between the ages of 10 and 30, then she should have annual screening MRI exams starting at age 25 and screening mammography starting at age 30. If her risk is greater than 20% by any model, or if she has a strong family history, then her annual mammography and access to supplemental screening should begin at age 35 or when recommended by her physician, usually not younger than 10 years younger than the youngest family member. For women who've had breast cancer who are diagnosed at age 50 or older and don't have dense breast tissue, then annual 3D mammography is preferred. But if a woman was diagnosed with breast cancer under age 30, or if she has dense breast tissue, then she should be offered supplemental screening with MRI as well. These are, of course, women with a history of breast cancer who did not have both breasts removed. And women with a history of breast cancer or not can continue screening as long as she is in good health or her life expectancy is 10 years. And there are several risk assessment models out there. I'm just going to talk about two of them. The National Cancer Institute Breast Cancer Risk Assessment Tool, or GALE model, can be used to estimate the 5-year and lifetime risk of developing invasive breast cancer. It includes the current age at onset of menstruation, age at first live birth, any female first-degree relatives with breast cancer, the number of previous breast biopsies, and whether or not any of these biopsies have shown atypia. It does not include a history of lobular carcinoma in situ, does not include any male relatives, doesn't include any paternal relatives, or any relatives with ovarian cancer. It does not estimate the risk of having a BRCA mutation, and this may underestimate the risk of developing breast cancer for Black and Hispanic women. But as we saw earlier, this is used to determine if someone is a candidate for chemoprophylaxis or these risk-reducing medications if her 5-year risk is 1.7% or greater. There's another model that's most commonly used, which we use routinely in our clinic, called the Tyrer-Cuzick or IBIS. It includes a woman's age, whether or not there's any Ashkenazi Jewish heritage, body mass index, and in the most recent version, also breast density. It includes her age at the onset of menstruation and menopause if she's postmenopausal, age at first live birth, use of any hormone replacement therapy, results of any breast biopsies, was there hyperplasia, atypia, lobular carcinoma in situ, family history of both breast and ovarian cancer in first, second, and third-degree relatives, along with male relatives. And this then calculates her risk of having a BRCA1 or 2 gene mutation, 10-year and lifetime risk of developing breast cancer. And so this is what this calculator looks like. We input all this data, and then this is a hypothetical patient here. This would be a premenopausal woman who's 45. She began menstruation at 11. She's premenopausal. Her first child was born when she was 35. She's 5'5" and weighs 140 pounds, has heterogeneously dense tissue. And so you can see on the top right then, her risk of developing breast cancer in the next 10 years is 4.6%. 10 years for the average 45-year-old, though, is only 2.3%. And her lifetime risk is 23.8%, whereas the population risk is 12.3%. Still relatively unlikely that she would have a BRCA gene mutation, even though this hypothetical woman had a maternal aunt and a grandmother with breast cancer, but they were both postmenopausal, 60 and 70. And so she would be a candidate for high-risk screening with this calculated lifetime risk of nearly 24%, but would not meet criteria for chemoprophylaxis or risk-reducing surgeries. And so in conclusion, breast cancer continues to be the most commonly diagnosed cancer in women and the second leading cause of cancer death. Breast cancer incidence continues to increase and mortality continues to decrease, but there are ongoing significant racial and ethnic disparities. Primary prevention is important. There are modifiable and non-modifiable risk factors, but there are familial risk factors and genetic risk factors that we cannot control, reproductive risk factors, but also lifestyle and behavioral modification. And secondary prevention or screening really depends on knowing one's risk. So it's very important that women know their risk of breast cancer and are being proactive, because as Ben Franklin said, an ounce of prevention is worth a pound of cure. Thank you, and if we have a couple minutes left, I'll be happy to answer any questions.
Thank you so much, Dr. Oxley. That was very informative and very data-dense presentation. We did get a few questions that came in during your presentation. We have demographic markers, but do researchers know enough about the environmental causal contributions to these pathologies to partially explain these differences?
I'm going to say no, we don't know enough, which is why it's so important that there's research in all aspects, the biology, the sociology, the economic impact, the environmental influences, because we know that it's not just genetics. For example, US-born Black women, as mentioned earlier, have different outcomes than Caribbean-born Black women, but most US-born Black women are descendant from West African populations because of the slave trade. And so you'll find that the patterns of these tumor subtypes are similar in US-born Black women to Western African women, but they're different in East African women. And so it's interesting to figure out the contribution of genetics versus environment. No, we don't know enough.
Thank you for that. Can you explain the BRCA subtypes and how the hormonal aspects vary, and then the diet implications?
So the breast cancer subtypes, invasive breast cancer is, there are 3 receptors, the 2 hormone receptors, estrogen and progesterone, and then the 3rd receptor, HER2/neu, or human epidermal growth factor receptor 2. Most breast cancers are hormone receptor positive, and so these are the ones that are most driven by obesity, where we can have the most impact on exercise and weight loss. These are also the cancers that are increased with the increased alcohol intake. There's a lot of research into specific foods. I tell patients there's no superfood, there's no one food you need to swear off, but certainly eating a diet high in fruits and vegetables has been shown to be improved, to associate with improved breast cancer risk. And again, limiting alcohol, not smoking, getting regular exercise.
Another question that we have is comparing the population with cancers in males of comparable ages, ethnicities, background, and locations. We know that it's lower incidence with male patients, but is the trends that are seen in terms of comparing the aggregate to subgroup populations, do we see a similar pattern for males?
Breast cancer diagnoses in men have been pretty consistent at about 1%. The vast majority of male breast cancer is hormone receptor positive. So no, we don't quite see the same trends in men as we do in women with breast cancer, and I don't have data on other cancer types in men.
And it is October, Breast Cancer Awareness Month, and we did have a question about someone who shared her diagnosis very publicly, and that was Suzanne Summers, who recently passed away. she was a proponent of bioidentical hormone replacement. Do you think that caused her breast cancer? And is there any difference in bioidentical hormones and then the synthetic for cancer risk?
So I don't know anything about the specifics of Suzanne Sommer's cancer diagnosis, but bioidentical hormones are still hormones. And there's no data on the safety of combination hormone replacement therapy in a patient with a hormone receptor positive breast cancer. There is some data on the safety of using vaginal estrogen in women with breast cancer who have problems with vaginal dryness that are not able to be treated with moisturizers and lubricants. So that is felt to be safe. But hormone replacement is hormone replacement, and so there's no data on the safety of combined hormone replacement therapy, whether it's estradiol or plants.
And because it is Breast Cancer Awareness Month, the question is self-exam important for all of us to be doing, knowing our risk factors, taking care of ourselves and our own self-care with exercise and diet? I think I felt a little guilty when I was watching your presentation, like that, oh, I better rethink my lunch plan and maybe build in some exercise for myself today. But when we're doing self-exam, that is a prevention tool. Do you recommend that women do self-exam? How frequently, and how should they learn?
Right, so that's a great question. And so breast self-exam has kind of fallen out of favor. The idea being that it implies a strict, regimented inspection of one's breast for the purpose of finding cancer. That has then been replaced by breast awareness, which I think is a great term. Every woman over the age of 18 should know how her breasts look and feel, so that if something changes, she can let someone know. And visual inspection, look in the mirror, arms up and down, exam in the shower, exam laying down. I tell women the goal is not to make a topographical map of your breast tissue, nor is it to say, this is a cyst, this is a fibroadenoma, oh, this might be a cancer. But just to know what her tissue feels like, so if something changes, she can let somebody know. Some women say, oh, I check every day in the shower. You're not going to notice something if you check every day in the shower. So for premenopausal women, about a week after the period ends is usually the best time. The hormone levels drop, the sensitivity is lower. For postmenopausal women, pick the first of the month, pick the last of the month, pick your birthday date, anything you can remember. If you miss a month or two here or there, don't beat yourself up. Again, the goal is just to know what the breast tissue looks and feels like, so if something changes, you can let somebody know.
I think that's great advice, and really level-headed. We're not expecting any individual to take personal responsibility for knowing their breast topography, as you indicated, but really to just be aware of our own bodies, our needs, and changes that occur, and knowing when to bring in the medical professionals to make that difference for us. I've got to say, this was a fascinating presentation of the data, and I want to thank you, my fellow board member, Jill Oxley, on behalf of myself, the MBCC board, and Cheryl Osimo, MBCC's executive director. I want to thank you, Dr. Oxley, for this very informative discussion today, and I want to thank all of our many listeners for joining us. For those interested, the recording of this webinar will be made available later today on the MBCC website at mbcc.org. Have a good afternoon, everyone.
Thank you, Dr. Malgus.